Good morning, good afternoon, and good evening. Thank you for joining us for today's PathLive Forum titled Improving and Expanding Self-Testing for Health Equity. My name is Dr. Kimberly Green, and I'm the Global Program Director for Primary Healthcare at PATH, and I'll be facilitating our exciting discussion today. We'll start first by going over a few logistics. We very much want to hear from you during this conversation, so please share your questions and comments with us by submitting them in the chat or Q&A box at any time during the webinar. We'll have some time at the latter half of the session for audience Q&A. In fact, I'd love to ask a question to all of the attendees now. Today's event is all about expanding access to self-testing as part of Health for All or universal health coverage. Our speakers will share their thoughts on this topic, but first I wanted to ask each of you to respond to this question. In your opinion, what added value does self-testing offer as part of routine healthcare or health emergencies like COVID-19? Please type your answers into the chat box and send your answers to all panelists and attendees. Thank you. Please note also that this call is being recorded, so it is available for those who are not able to join today. So I see we have participants joining us from all over the world, government representatives, community organizations and NGOs, donors, as well as private sector partners and others. Thank you so much for joining us. So as an overview for our session today, I'll introduce our panelists and then briefly frame our conversation before diving into facilitated questions with each of our panelists. So we are honored to be joined by an incredible group of speakers. We have with us Mr. Inchul Chung, who is the head of IVD and Medical Diagnostic Business Division at SD Biosensor. Dr. Betty Marembe is also with us. She's the country director for PATH Uganda and brings several years of experience in HIV self-testing programming. Dr. Fifa Araman is joining us. She's a civil society representative on the Diagnostics Pillar and Facilitation Council for the ACT Accelerator on the COVID-19 global response, as well as principal consultant for the Matahari Global Solutions and special advisor for health poverty action. She's played a pivotal role globally in advocacy related to COVID-19 self-testing access and test and treat strategies. And finally, we'd like to welcome Mariana Vilares. She's the team lead on STIs, HIV, and viral hepatitis with the Ministry of Health in Brazil and has done quite a bit of very innovative work around HIV self-testing that she'll be sharing with us today. So a profound thank you to all of our panelists for joining us today. And before we move on to Q&A rounds with our panelists, I just wanted to frame self-testing and where we really are now. So next slide, please. At PATH, we are very passionate about increasing opportunities for self-care and as part of that self-testing. And we are grateful to have had opportunities to work in partnership with a number of ministries of health, affected communities, non-governmental and community-based organizations, manufacturers, as well as donors and technical partners, all in advancing self-testing primarily over the past number of years for HIV, but more recently for hepatitis C and for COVID-19. We're currently supporting work to increase access to self-testing in 9 countries. And next slide, please. So as part of this work in HIV self-testing, there's been a tremendous amount of learning in terms of what really works for people. And what we've learned is that what people seek when they want a self-test is really convenience, confidentiality, and choice. And what I really like here on this slide is some of the work that's been done by the CDC in the United States. And you can see at this table, they really have been very thoughtful about choices that people need to make around HIV self-testing, different kinds of products, and accessing a self-test in different ways, through a pharmacy, for example, or through home delivery. Next slide, please. So with COVID-19, we very clearly pivoted and realized that self-testing was not only a really important component for HIV testing overall, but it really became a lifeline during a number of the lockdowns when it was very difficult to access facilities. Self-testing enabled people to still get diagnosed for HIV and to still access treatment, and was also used to help people who were taking pre-exposure prophylaxis to routinely monitor their HIV status while on PrEP. So with all these adaptations, with all this learning from HIV self-testing, what have we learned and applied with COVID self-testing? So next slide, please. So we've done a recent review, and this is available on our website, where we've looked at, of all of the COVID tests that are out there, nearly 2,000, 95 are dedicated to COVID self-tests, which is impressive compared to, HIV. There are just a handful of self-tests that are available. But what you can see here is that of those 95, only a third are available in lower middle income countries. Next slide. And so then as we look at who's manufacturing or making COVID self-tests, you can see there's relative distribution across a number of different continents, but within Africa, there is no manufacturing that we identified. And very starkly, self-test access is mostly seen in high and upper middle income countries. So there is a lot of work that still needs to be done in ensuring that there is equal access to COVID-19 self-tests, as well as really thinking about equity for all self-test products now and moving forward. So with framing some of the key opportunities and challenges with self-testing, I'd now like to turn to our panel. And I'd like to start first with you, Mariana. So, Brazil has led on innovative work in HIV self-testing through your leadership and others. And I'd love to hear more about why HIV self-testing was prioritized as an option among other HIV testing options, and what gap did it fill? Over to you.
Hello, everybody. Well, I'm very happy to be here today to talk about the Brazilian experience. I'm also a little nervous to be on this amazing panel with such important people and a big audience, perhaps 600. I don't know. Well, in Brazil, we have the SUS, a unified health system that has equity as one of its pillars. So since 2012, we have made huge efforts to expand access to rapid testing in primary healthcare services. And we perform almost 1 million rapid tests each month in more than 20,000 healthcare facilities. But Brazil has an epidemic concentrated among key and priority population who unfortunately feel stigma and discrimination, facing barriers to accessing these health services. So aiming to reach this population, in December 2018, we started free HIV self-testing distribution using two main strategies. The first one is distribution outside health services, especially in places of sociability of key populations by health professionals and in partnerships with NGOs. And the second one is distribution to people to have been tested for HIV and other STIs at health facilities for secondary distribution to peers and sexual partners. In both cases, each person can take one HIV self-test for themselves and 5 more tests to peers or sexual partners they think might benefit from this strategy. This strategy has been very, very especially important during the pandemic, when the demand for rapid testing in service has dropped significantly due to the social distance recommendations. Well, the results. From December 2018 to December 2021, we distributed almost 450,000 HIV self-tests. And we observed that, first of all, HIV is highly acceptable and very easy to perform. NGOs play an important role in reaching the key and priority population. We have successfully reached our target population, key and priority, and young people. For instance, 20% of testers were first-time testers, 42% were young people, 52% were gay and other MSM, and 5% were trans people. It seems a low proportion, but it's higher than we observe in health services. The main advantages reported by the users were privacy and personal empowerment. I see in the chat that people today are all talking about these two big things regarding HIV self-testing as really important advantages. Also, the results show that people prefer to self-test alone or with someone they trust. And most people seek confirmation after a positive result. So we think we are in the right way of bringing testing options for these hard to reach key and priority population. That's it.
Thank you. It's phenomenal to see what you've been able to achieve using self-testing as a way of reaching people who are not otherwise being reached. So really as a key strategy to address health equity in the HIV program. There's a lot that we can learn from how Brazil has approached HIV self-testing and how it can be applied in other places. So Fifa, I'd like to ask the next question to you. Through your role with the ACT Accelerator, you have very effectively advocated for equitable access to COVID-19 self-testing and antivirals as part of test and treat approaches for communities that are not able to access this dual approach. So with WHO now finally having guidelines on COVID-19 self-testing, have things changed now that these guidelines are out? Do you see increased access to self-testing in lower middle income countries? And if not, what more needs to be done?
Thanks, Kim. So progress is really slow, and there are multiple reasons for this. I'll start with the positive, because since the guidelines have been released now, large donors and large commodity purchasers such as the Global Fund can purchase self-tests. And of course, prior to the guidelines, they were deploying professional use antigen tests, but these, of course, were limited in use just because, there's some practical details, such as there's only one package insert for a box of 25 tests, and you can't kind of give them out to like homeless people and sex workers and people, it's just not practical for self-test reasons, right? So now the positive thing is that Global Fund can deploy them. There's been some positives in terms of the fact that FIND and UNITAID will imminently announce that there'll be 21 countries working on advocacy projects to increase access to self-testing. And, that covers a number of different types of projects. They've got projects coming up on influencing key opinion leaders in the communities in Burkina Faso. They've got projects on building political will in India, Kenya, and Zimbabwe. They've got work to increase self-testing in fragile settings such as Afghanistan and Pakistan. So there's a bunch of positive things coming out in terms of advocacy, but you need the advocacy to increase the access to self-test and the actual access to the commodities. So all of this could have happened earlier. And obviously, I'll talk about what we need to improve in the architecture to make sure this lag, this delay doesn't happen in the next pandemic. But we're still, there's sort of a lot of, it is still quite slow, also because there is conservatism on the ground. And this exists predominantly among a lot of lab folk, actually, who are of course, convinced that PCR is the gold standard, and PCR is the gold standard in terms of, obviously the accuracy of the results and all that. However, there seems to be a lack of a public health approach in a number of countries where, this is about a person's right to their right to know about their health status, right? And the right to protect their family. It's the right to autonomy of what they can do to protect themselves and their immediate community. So it's more about, some of these ideologies are focused on, if there's no surveillance, what's the point of self-tests? If, I can't trust my people to link to public health action, which we've called out as racist. We've gone like, what are you trying to say? Like, self-tests are good enough for the global north, but not for the global south. So we've called that out quite directly and gone, this is really problematic discourse, but some of that remains. And we're trying to tackle that. And in terms of what countries, well, I start with what donors need to do really quickly, is that donors need to start finding testing sexy, because, everybody wants to fund vaccines and nobody wants to fund tests, which is like, reopening economies, which everyone is so focused on. Even if you don't want to think about it in terms of health, if you want to think about it in terms of the economy, reopening economies, testing is the number one method as to how you do that, right? And in terms of countries, this conservatism of, if there's no way to do surveillance, then we don't self-test. That's just, an approach that isn't right. Yes, surveillance is useful, and we know that. But there's also, and more importantly, the need for the person to know their status and be able to control what's happening in their surroundings and protect their families. And happy to talk about the global health architecture later.
Perfect. Thank you very much. Yeah, so bottom line is that, in the mix here, there are factors of paternalism and racism, just really around who gets to access a self-test for COVID and why, and what the relative value of that is. And I wanted just to link back to the point that was made by Mariana, where she's talking about with HIV self-testing, 400,000 HIV self-tests made available in Brazil, and without necessarily having that surveillance in place that's directly linked to self-testing. And the majority of people made decisions that made sense for them based on their results. And there's been a net benefit for individuals and the public health system. Secondly, you made the point that we need to make testing sexy, and you were absolutely right. And I look forward to hearing more about how we can do that in the next round of questions. So now, Betty, over to you. Uganda has been very effective at scaling up HIV self-testing. Maybe not as many HIV self-tests as Brazil, but maybe second in the world, really. HIV self-tests have been made available, and through a range of differentiated models with strong Ministry of Health leadership and strong community engagement. So from your example, through the work that you're doing with the UNITAID funded and PSI led with Path Star project, what needs to be done to increase access to COVID self-testing in Uganda, and how can organizations like Path help? Over to you.
Yeah, thank you very much, Kim. I think you raise very clear points that we've had quite a successful process with HIV self-testing, and I think there've been a lot of lessons learned. And I know that we really can take those lessons forward into COVID-19 testing. But I think there are a couple of background issues that we need to address. I think one of the things that affected the scale up, the acceptance, the inclusion of self-testing was the part around dealing with myths, dealing with stigma for HIV. And I think for us here in Uganda, around the times when we really had high numbers of COVID-19 infections, it was really a difficult time around myths. The communication wasn't as great as it needed to be. So I think that part needs to be addressed. The messaging around COVID-19 testing, access to treatment, treatment outcomes, availability of all the necessary care that is needed needs to be more available, so that people feel like once I test, I can actually receive care. And I think that's a part that we need to get a hold of. The other part is around the market. Looking at the entire population who actually would benefit from self-tests. We've been able to isolate that for HIV self-testing. We need to think about the population in regards to COVID-19. Where are they most likely to find the tests, and how do we make them available there? What's the cost that they will have to meet in order to access? And what distribution models do we put in place? I think we've tried a couple of things with HIV testing, self-testing. We've done private sector specific models. I think we should be at liberty to learn from those, but I think we should also be at liberty to reinvent or innovate around COVID-19 and how it's played out within the community. I think the other thing has been the policy environment. Policy plays a big role. I think once people see that there is a policy backup, they will, it sort of instills that confidence not only within the population, but also within the health worker force to promote it and say, I mean, you don't have to come here. We've approved, this has been approved, and you can actually give these tests to everyone at home. So making a good and a strong policy environment around COVID-19 testing, its access, its availability, and its contribution to the entire program, I think is helpful. And I think finally, something that we all need to think about that we were able to sort of map out for HIV was what's the pathway, what's the link, or what's the test and treat linkage for COVID-19. We have it for HIV. We know that you test, you'll come back to the facility. It's not entirely very clear for COVID-19. And so people sometimes have that question, okay, now I have tested, where do I need to go? And I think during the peak of the pandemic in Uganda, we had issues around admissions. People wouldn't be admitted into hospital. So it sort of kept everyone on the other side of, I don't want to find out. I don't know where to go. So we need to sort of define that pathway. What's the test and treat connection for COVID-19? And I think once people have that, then we will be able to increase the number of people that can access HIV self-testing. I mean, COVID-19 self-testing, as well as we have done for HIV self-testing. Yeah.
Thanks, Betty. That's brilliant. Basically you've laid out the program, what elements are needed using, health system strengthening approach, what we need to think about with demand, understanding what will resonate with different individuals, where COVID self-tests need to be made available, how to address stigma in the first place. And really importantly, as was so important in the early days with HIV, is what care is available and how do you access it and how valuable is it? And I think there's a lot of work that still needs to be done on the treatment side for COVID, where there's even greater inequities right now with antiviral access in high-income countries, certainly than there is in lower middle income countries. So thank you for that. Now I'd like to move to you, Inchol, and I'd really love to hear more about your experience as a manufacturer. SD Biosensor's COVID-19 self-test was very early to market and has been available in a number of countries. And we have seen with global demand for self-testing or testing in general really fluctuate significantly, that must have posed a lot of challenges to a manufacturer such as yourself and how to forecast and plan. So how have you navigated this complex demand and supply environment? Over to you.
Okay, thank you for having me. This is Inchol Chung from SD Biosensor. So after having a HIV professional test WHO pre-qualified in 2019, we had a plan to launch HIV self-testing in the market and also plan to go through the WHO pre-qualification for that. But as pandemic hits worldwide in late 2019, we had to focus on development and supplement of the COVID self-testing. At the beginning, there was many challenges to develop the right products for the right usages. As you all know, it was antibody test that most of the countries and companies introduced as a COVID detection products. It gives a lot of confusion to the patient and healthcare systems. However, SD Biosensor had experience to develop SARS-CoV-1 before around 20 years ago. It helps us develop quality SARS-CoV-2 antigen test in short period of time. After that, global organizations like FIND and PATH gave us great help to validate performance of the products and usability of the products. Therefore, we could acquire the first WHO pre-qualification of SARS-CoV-2 antigen test. It was such a fantastic collaboration for global organizations and private entities to fight against the pandemic. But shortly again, we had to face a humongous level of challenges in terms of production. The demand from the countries were super high. It was never been be higher before, comparing to HIV's malaria test. And also the each government and countries need test kits very urgently. Therefore, SD Biosensor had to make big decision on huge investment of new factories, massive recruitment, automation assembly, and procurement of accessories. As a result, from 2019 to today, SDB could provide more than 1 billion tests of COVID tests to the worldwide. It was not an easy decision, but right decision to help countries to fight against COVID. Thank you.
Thank you for that. You know, it's always really interesting to hear a manufacturer's experience, and particularly with something so unprecedented as COVID-19. And it sounds like your company really upfront invested quite a lot just to make sure that you had the supply available to meet demand. But we'll come back to you in the next round just for some more recommendations, really, and how we can even out supply. As we know, there will be, in addition to our current diseases that exist, there will be others, and we'll need to be ready for those as well. So thanks to the panelists for the first round of questions. And so what we'd like to do now is to move into where do we need to head with self-testing technologies, with innovation. What do we need, and how can we learn from what's not worked well up to now in terms of issues related to equity and access? How can we address that moving forward? And so I'd like to first start with you, Mariana, and really focusing on the experience of Brazil in HIV self-testing. How can this experience be leveraged for addressing other disease areas? So over to you.
The percentage of people who know their diagnosis in Brazil rose from 69% in 2012 to 88% in 2020 due to the expansion of rapid testing in primary care and in extramural testing carried out by health teams and NGOs. And this shows that the closer the test is to the people, the greater the reach. But to get to even more people, self-testing is fundamental. It's an incredible tool for individual autonomy, and probably more and more self-tests will be available in the future. It gives an opportunity for those who can't go to health services during opening hours, and for those who don't want to take the test in front of the other people. It allows to test in a comfortable place, perhaps with someone they trust, and it facilitates timely testing for those who need to test more often. And it also can avoid long waiting in lines and allow health services to focus their efforts on the people who need care. This was a real problem in Brazil with Omicron in January. One thing we learned in these 3.5 years is the importance of communication. Betty already told a little about this. Our experience with HIV self-tests showed that the information for the user needs to be very clear in 3 moments. So before the tests, it must be clear who should do the tests, when to do the tests, and what are test limitations. As an example, I can mention the window period of HIV self-test, of HIV. So it needs to be known by the user. Then during the test, it must have clear instructions for use with step-by-step images so that user can perform the test and read the results correctly. It's very important. And then after the test, and most important, perhaps, Dr. Betty already talked about it too, there should be clear guidelines on what the result means and what steps to follow based on these results. So people can protect themselves, their families, friends, and the community. And in addition to the testing itself, the health system must be prepared to advise, guide, and carry out the necessary complementary exams for users who seek health units after a positive results. Lastly, I believe information, education, and communication are fundamental to successful self-test implementation. With more and more self-tests available, the population needs to have clear recommendations to rely and to follow. That's it.
Thank you. That's brilliant. It's a brilliant vision where people have greater access to self-tests for a number of different disease or health areas. And as you, very articulately stated, really that promotes their autonomy around their own health and decision-making of when they want to test and why and what they want to do with that information. And then the wraparound approach where the health system is built, around really supporting people with the right information and how to seek follow-up testing or care as is needed. So that's exactly the way we need to be thinking about self-testing moving forward. So thank you for that. So now I would like to move to you, Betty. Uganda is one of the few countries that has a national policy on self-care as part of its commitment to universal health coverage by 2030. So how does self-testing fit within Uganda's commitment to self-care and UHC, and what opportunities are there for innovation? Over to you.
Yep. Thank you very much. You rightly said Uganda is one of those countries, and I think we're happy that we've made some steps forward. What I must say is that a lot of our self-care guidelines were based on SRH services, and we're thinking that maybe we need to be a bit more broad, a bit more holistic, and not just limit ourselves to that service area. But the good thing is that we have started, and I think we can be able to make it broader. I see, and we all really look at it, self-care, self-testing as one of those low-hanging fruits as far as being able to achieve universal health coverage is concerned. UHC has that focus on access, and then also has that focus on cost. And when you look at what data is available, I'm not sure how many developing countries have that data, but WHO estimates that across the world and all our healthcare facilities, we are in short supply of about 18 million health workers. And in order for us to be at that optimal point, we need to have those identified, absorbed, enrolled, and established. But that takes a lot of money, and I don't think a lot of countries are going to be able to achieve that within the next 10 years. So I see that self-care is self-care, self-testing is that part that meets us halfway. Are we able to transfer some of the care that's needed to individuals and train them and support them to be able to do it well? And so I feel like I think we are not, within the UHC circles, we are not talking as much about self-care, self-testing as we should. It seems to be like our quickest sort of mode of delivery or mode of transport to what we want to achieve. If a significant population, if a significant number of people are able to do self-tests, are able to self-care, then we will reduce this 18 million gap to something, to 10, maybe to 10 million or even less, because we will have taken away the burden of care, healthcare, from the facility setting to the homes, to the communities, and to all those other settings where individuals are able to care for themselves. So one of the few things that I think we sort of need to think more deeply around for each program, are there opportunities for self-testing for each disease areas? Are there opportunities? It's good we have people from the manufacturer's side as they think about tests. Are they thinking about that concept? Are they thinking about the avenue of self-testing so that the kits or the test kits that they make are easy to use, are able to be easily accessed? They can be kept at normal temperatures. We don't have those whole facility restrictions that usually come with a number of testing kits. We also have to think from a policy front. I know healthcare and a lot of the specialties, really, everything seems to be looked at as, if you don't have a health worker, if you don't have a specialist of some kind, then you can't do anything. And I think we may need to think about demystifying some of those and being able to look within the spectrum of care. What is it that individuals can take on? And from the point of diagnosis, can we be able to promote those? Can a person who's being diagnosed today be taught how to do components that are really deemed able to be taken off by the self-care bits? I also think the training of health workers, midwives, nurses, doctors, lab specialists needs to take that side of self-testing, of self-care into the whole package. There should be a thinking for all of us that says, I'm going to be out there to care for patients, but I should transition them into self-care at a certain point. And so how do I do it? How do I prepare them? And how am I available for them? And I feel like maybe we are not concentrating a lot on self-testing and on self-care because we don't know what the cost reduction contribution comes from it. Maybe there is need for some teams, and I think PATH can really be able to do some work around if a proportion, maybe a 40%, maybe a 50% or a 60% of the population we're looking at was able to access self-testing or self-care. What's the reduction in terms of cost of health worker force time that would take away from this lab specialist, from this clinician, and from whoever? And then that leads us and takes us closer to the access that is required under UHC and the cost in that regard. Yeah, thank you.
Thanks, Mari. Yeah, I mean, I think you're asking some really good questions around what is the offset or cost savings to the health system overall by really promoting access to self-testing, which is really an important one. And I hope that, yeah, we will see more investment in really understanding that. So now I would like to move over to you, Inchul, and just ask a little bit about, you know, with everything that you've learned with COVID-19, how is your business model going to change? Now that you have very high capacity manufacturing lines, speed of development that was put in place for COVID-19, and what key factors might you consider for decision-making around future development and manufacturing of self-tests? And what kind of help might you need from others out there, you know, regulatory folks or others in thinking this through? Over to you.
Yes, for me, there are three different questions. Let me go through the one by one. And regarding the business model changes, previously we had one Korean factories during the pandemics and made enormous investment on these factories only. Due to the high investment, we could deliver 200 million tests per month capacity for self-testing and also professional RDT test. But as you know, it is not certain to have such a high demand in the near futures. Maybe, maybe not. So we had to make a plan to set up the factories in Brazil, India, and Indonesia inside of low middle income countries. And we send out the assembly machines and skilled people to those factories to facilitate the production of the HIV, malaria, STI, those WHO pre-qualified tests for LMICs. We believe it will reduce a significant amount of cost, such as transportations and building up the basic stock levels. And I believe it is also same interest to global community like WHO and donors to achieve their public healthcare targets. We still need to go through the WHO site audits for those factories in order to facilitate. But I hope WHO to take a look at it as enhancement of public healthcare for LMICs. So regarding next question is regarding the key factors of decision making for self-tested business. Before COVID, there was a trend to adopt self-testing in the public healthcare, such as HIV, HCV, but the level of the demand wasn't high enough, to be honest, for the manufacturer to consider it as a core business. But after COVID, the around approximately 5 billion world population had a chance to test COVID antigen test with a self-test, or at least they hear about self-test. So this gives a significant effect on accessibility of the self-test to the public healthcare systems. But there are still many factors, I believe, to consider for private company like Biosensor. First, most of the countries, including global communities, do not have solid policies for self-test at this moment. In order for private companies to make a plan for the development or maintaining capacity of the self-test, there should be long-term procurement plan from the country programs. And WHO pre-qualifications over the different self-testing to provide initiative to private entities. For example, number of the WHO PQ items for self-test should be expanded. Currently, as you know, HIV, HCV, and COVID are only the items, but it can be expanded to other STI or infectious disease, including malaria and dengue. And the total volumes of self-test procurement by the donors should be increased to certain portion compared to current ones. That is the what I believe, what the company believes. The secondly, from the company perspective, the challenge of the self-testing was lower performance and lower usability that might provide wrong test results. So the companies need to focus on innovations of the self-test in order to increase the usability and performance for the lay users. That is what I believe the inputs and also the decision-making the factors for the companies.
Thanks, really helpful to get your insights on what the key factors are moving forward in terms of self-testing and making self-tests available, and also just really the critical role that we know WHO also plays in supporting pre-qualification and also those normative guidelines and policies that can help to incentivize manufacturers to produce affordable self-test kits. So I want to turn to you, people, with the last question. So this really focuses on, the current situation with very stark and persistent disparities that we've seen in fair and equitable access to COVID-19 technologies in lower middle income countries, not only vaccines, but also, as we've seen and has been shared by you and others, with diagnostics, including with self-test kits and also treatment. So how do things need to change to fix the current state of inequity? And how do we ensure that this does not happen next time? And I know this is a huge question, and I really appreciate your take on it. Thank you.
Thanks so much. Huge question. I'm going to try to sort of summarize. And just on the current state, what we're hearing from countries is that they want to move on from COVID, right? They want, they want to move on from COVID, the momentum's gone, all of that. So taking into account what countries are telling us, I think the best route for now is integration of COVID tools into existing disease programs. And that may involve, for example, when someone comes in for a HIV test, they are also offered a COVID self-test. You can do this for multiple diseases, of course, diabetes, malaria, whatever, on and on. But serious work needs to start now to look at a new TRIPS order. And for diagnostics, maybe this doesn't matter so much, but for therapeutics and vaccines, it definitely does. And also a public health order change, which, Africa CDC has obviously been speaking about a lot, been really dissatisfied with the global North white-led COVID response that has happened. And it's quite important that that changes because, the self-test guidelines were delayed for 8 months for a reason, right? And so many people died in those 8 months. It's because people were saying people in the global South won't know how to link to treatment. And each time we were like, what? So, it is an issue of diversity. It is an issue of the public health order that needs to change. Now, we're already working on the future. We're already working on a new global health architecture for future pandemics. And we're doing that with the WHO, but also jointly with the G20 and the presidency of the G20. Now, the global health architecture discussions next week will be in Lombo. I'll be speaking there in the middle of the night, my time, actually, in 2 in the morning, about what we need in the new global health architecture for pandemic response. And one of the key things we're requesting is agility, because the fact that it took more than 8 months, I say 8 months because I calculated from the first time I exploded on a call on self-tests because it was taking so long, but I'm pretty sure we were angry before that. So, the fact that WHO's guideline development isn't sufficiently agile for emergency response is something that really needs to be tackled for the future. We also need more racial sensitivity in the emergency response team. This whole thing that sounded very much like we heard in the HIV response. Africans can't tell time. That's what we heard during the HIV response, right? And they were saying very similar things in terms of self-tests, right? Which is people won't know how to access a treatment. People won't know how to link to public health action. I'm like, are you hearing yourself at all? That's what we want to see. We want to see diversity, because that way we avoid all this that hasn't been unlearned, right? One of the things we want to see as well in the future pandemic response is an LMIC council of experts. If people don't instinctively consult LMIC experts, and I'm talking about Black and brown epidemiologists, health comms expert, community mobilization expert, nurses, pharmacists, all these LMIC people, if people don't instinctively do that, we need to build in something in the architecture to make people do that. And one of the things we've been thinking is an LMIC council of experts, composing individuals who are eminent in their fields from Cote d'Ivoire, Rwanda, Nepal, Brazil, everywhere, to make sure that these decisions at the global level come through a lens of the global South before commodities are deployed. And one of the things, and I met Dr. Tedros a month ago to talk about the future pandemic response, among other things. And one of the things I want to see in diagnostics is a consolidation of expertise at the global level. And we know, of course, that diagnostics experts are in the HIV department at WHO, in the TB department. There's PATH, there's CHAI, there's people like myself, there's MSF. I can't remember when's the last time all of us have been in the same room. And that's one thing I said to DG was like, we need everyone in the same room to talk about a more consolidated, coordinated effort on diagnostics to make sure that, all these problems in diagnostics doesn't happen again. Rushing through, but just wanted to answer the question that was in the chat as well, which is what are the best practices for proper reporting while doing self-testing? One of the things that has been neglected in this COVID response is health systems, and health systems, one aspect in particular is the role of community health workers. Of course, having an app is great. Like, here in Britain, when we did a COVID self-test, we just reported it on the app, and the app would automatically tell us whether, what would happen from then, how long we have to self-isolate. If you're high risk, Paxlovid gets delivered to your house. You can order the self-test online, all of that. And that's the privilege of me living in the United Kingdom, right? But where that's not possible in the global South, that we need to empower, and we need to salary community health workers to be able to have the tools to log that in their tablets or whatever it is. So that's definitely something that needs to be done. I could talk about this all day, but that's all the time I have, and happy to answer any questions.
Thank you. That was brilliant and really laid out very clearly the direction that we need to go in terms of just redefining the global health architecture overall, and who's at the table, and this idea that you're putting forward of having a LMIC council of experts across a number of different areas, really to just inform where investments are made, and what gets out there, and how quickly is really the way we need to move forward. And hopefully we'll address some of those barriers or challenges we faced with decision makers around guidelines where things have been significantly delayed because of specific viewpoints of those who are making decisions. So I know we have some brilliant comments in the chat, and all four of you have addressed the comments that have been made really around how to address stigma, linkage to care, good communications. So thank you for that. But I think, one of the key questions that is really posed has to do with leadership around self-testing. And if any of you would like to address this question around national policy and leadership in self-testing, and kind of, what do you expect, or what does it take, even, when those guidelines come from WHO, what do you expect to see or hope to see in the countries where you live around good leadership from your ministries of health on self-testing? And if anyone wants to jump in, Betty, looking at you, or
yeah, I will start, and then I think my colleagues can join. I think what everyone expects is really that very open acceptance, but a willingness to be able to look into country specifics, country dynamics, to determine what's workable within that country. I think Dr. FIFA brought out the timeline. Sometimes guidelines will come out of WHO, and we will spend quite a long time being able to make what would work within the country. And I think that makes everyone feel like maybe this is not urgent, maybe this doesn't work. So a bit of that commitment to make it really, really work, make what's been known globally, tone it down to a country level and make it available. But also, I think policies are good on paper, but I think leaders and ministries of health need to look into what does it take in terms of resources, not only finances, but resources around human resources, logistics. What do we need to make that policy work? I think many times we stop at approving it, launching it, and everything else is left to everyone. And I think at that end, we only have a policy on paper. We do not have a policy in action.
Well said. Policy on paper, but not in action. So with that, we are at the end of our discussion, and I would like to give an opportunity to all of the panelists just to provide one or two sentences key takeaways, key messages that really, conclude where you think we need to be heading with self-testing. So I'll start with you, Mariana.
Thank you. Well, first, I am a self-testing enthusiastic. I really think self-tests are here to stay. Well, when planning to implementing any public policy, we necessarily must talk about high costs of health inputs if we want to expand access and availability of any health technologies. In Brazil, the price of the first HIV self-tests acquired in 2018 was $7. Then in 2020, we paid $4. But we still need to lower this price considering this is an expanding public policy. For instance, we pay $0.25 for each rapid HIV test purchased today in Brazil. And finally, recalling equity, we must discuss innovative strategies and partnerships to reduce the logistics cost of delivering the tests, especially when we think of a country like Brazil with a continental dimension, high social disparity, and regions that are difficult to access.
Thank you, Mariana. Over to you, Inchol.
Okay. SD Biosensor has been actively participating to the fight against COVID-19. And we believe the self-testing that are newly adopted for LMICs will play a great role again to stop the pandemics. We are very proud and glad for being able to provide our solution to the world. But at the same time, the manufacturers like us have been greatly motivated by the different global stakeholders, especially global organizations such as PATH and GATE foundations. And it is very important to give right messages and incentive to the manufacturer. In fact, sometimes the developing and supplying innovative kits needed in the LMICs may not be the strategically interesting for a company like SD Biosensor. But different organizations like PATH are trying to inform and support manufacturers for this. So we hope there will be more projects with the manufacturer in the future. And with the help of the organizations, we believe if we have to face a next pandemic, we will be much more prepared. Thank you.
Thank you very much. Over to you, Betty.
You asked a question that where should we go, or where with
any last words you have, anything you want to
Yeah, I think we should go everywhere where it applies. We should go everywhere where it applies and move fast and fast enough. I think we've had pregnancy tests for a very long time, but see how long it took to even us start thinking about HIV self-testing. And now I think we've been a little more faster with COVID-19 testing. So for every disease area where we think it's applicable, it can be implemented safely. I think we should go with that line of thinking. And probably something that we need to bring into the thinking process is about waste disposal. I think because as we think about self-testing and putting all these kits out there, what are the disposal mechanisms? And I think that also will be helpful if the manufacturers can think that we are going to have a lot of these disposed of everywhere. What does it mean and how safe is it?
Yes, yeah. Thanks, Betty. And last words, FIFA.
Thanks. Hard to put everything into one sentence, but I think one thing I haven't mentioned is civil society involvement. And we often focus on having civil society on the boards of, say, treatment, decision-making panels on treatments, decision-making panels on vaccines, but not really diagnostics. And there's a lot of conservatism on diagnostics. We need more sort of Ministry of Health officials that are kind of like Mariana said, right? The self-testing enthusiasts. We need self-testing enthusiasts, and civil society are precisely the right group of people to go look, you're thinking about surveillance, but you're not thinking about our human rights. It is my right to have an access to self-test. It is my right to know my status. So just wanted to emphasize the role of civil society in changing the paradigm.
Thank you. I think between the four of you, we've clearly laid out where the world needs to head in self-testing, how to ensure the right kinds of engagement with communities and decision makers, how to make self-testing sexy, how to think about a wide range of products that need to be made available, how to think about primary healthcare and the role of community health workers in self-testing, the role of the manufacturers, the important role of WHO, and all of that combined, the imperative of speed and agility, which we haven't seen as much of as we had hoped with the response to COVID-19 in terms of making key technologies available in lower middle income countries. But moving forward, that is where we need to head. So my huge gratitude to our four brilliant panelists. Thank you very much. And I wish for the four of you to be in charge of decision making around self-testing and supply and demand moving forward. So thank you very much. Thank you for everyone who joined our session today, and we'll make the recording available for those who are not able to make it. Thank you.
Thanks, everyone.
Thank you. Bye-bye.
Thanks.
Thank you, bye.
Bye.